Thank you for that very kind introduction. Thank the committee for inviting me to give this. I want to make sure the audio is coming through okay. Are any issues?
Yeah, you're good, Todd.
Okay, great. This is the Harold A. Stein lecture. Dr. Stein was a giant in Canadian ophthalmology. He wrote or co-authored over 40 textbooks in ophthalmology. He co-authored the first textbook for the ophthalmic assistant, now in its 10th edition. He was the president of 3 major Canadian and USA organizations, including CLEO. He was one of the first to receive the Lifetime Achievement Award from the Canadian Ophthalmological Society. And he received the Lifetime Achievement Award from Orbis for all the international work that he did. So this talk honors him. I hope I do it justice. The title of my talk, Neurotrophic Keratopathy, Ophthalmology's Diabetic Foot Problem, is one that I think is appropriate, and I'll tell you why. And it's the first time I've given this lecture. I've talked about pieces of this before, but this was a great chance to put it together. I call this my older cranky ophthalmologist's lecture, and I'm not going to be presenting you any data per se, but then again, I would argue that we didn't see much data in any of the previous talks, and this is because doing prospective trials in neurotrophic keratopathy is extremely difficult, and in fact, the heroic work that was done for recombinant NGF is to be applauded, and they still had a lot of issues with that trial. I'll just say that as we talk about this, I've tried just about everything over my 35 years of seeing these patients, and I'm going to go back to some basics. I hope that what I present is actually very simple and that you see it that way, but I hope it's highly controversial too, because it wouldn't be one of my talks if I didn't try to stir up a little bit of controversy. Let's go ahead and move along then. And the first is, it's keratopathy. It's not keratitis. Neurotrophic keratopathy is the problem. You get a keratitis when you get secondary problems and you get inflammation. But if you just have a numb cornea, that's a keratopathy. And so you might very well have a keratopathy with a secondary exposure keratitis, or you may have an underlying zoster keratitis. But the underlying condition is a keratopathy, and I think it's important that we remember that, and it makes a big point here in terms of what I'm going to be talking about. Oh, how did that end up there? All right. So neurotrophic keratopathy has a lot of different causes. Things that destroy sensory innervation seem to cause this. Congenital keratopathy, neurotrophic keratopathy, is a heartbreaker. These patients live with this forever, and I applaud Dr. Ali for what he's doing to try to help these kids. Diabetes is a problem, and most of the problem is probably not basement membrane issues. It's neurotrophic keratopathy issues. We see post-surgical things even after giant retinal tears. That's the case up here on your right. Zoster commonly does this, and there are neurodegenerative diseases. The case on the lower right is a case of canvas that I've taken care of. Interestingly enough, you notice that I kind of skipped over HSV. And a lot of people have said, oh, HSV, we see a lot of neurotrophic keratopathy with that. I actually don't. It's rare that I have a patient who's had HSV who ends up with neurotrophic keratopathy and problems with healing. I suspect that's because I treat my patients very aggressively with oral antivirals. I minimize stromal inflammation, and that could be the reason. But the one on the lower left, I think, is the only case I've had of significant neurotrophic keratopathy in all my years of taking care of this stuff. And I think oftentimes other things may be at the root of this, and we'll get to that. So let's talk pathogenesis just for a minute. And I'm just going to be blunt as can be. We don't understand this disease. You've seen people throw up things about various growth factors and inflammatory factors that may play a role. We really don't understand the pathogenesis. We know that when the nerve is gone, something happens that leads to poor epithelialization and poor healing. But beyond that, I think we've got a long way to go in our field. Other things to consider. People mix and match all these cases. Not only cause of the sensory loss, but the depth and extent of the sensory loss will determine to a large degree the problems that patients have. And so one patient's neurotrophic keratopathy might not be the same as another doctor's. The type of neuron loss might be important. When we talk about Cochet-Binet tests, those only test mechanoreceptors, and those are only about 15% of the sensory neurons that are in the corneas. So they don't test the peptidergic innervation. We know that, and people keep talking about substance P, CGRP, insulin-like growth factor, things that are given off by peptidergic neurons. And they don't look at autonomic neurons either. So we really don't know what goes on here. Confocal doesn't really help us a lot because it doesn't discriminate neuronal type. We don't know what's a mechanoreceptor versus a peptidergic receptor versus an autonomic neuron. The role of the autonomic neurons has not really been explored. I think it needs to be. There's one paper, Mucosal Immunity, that I thought was pretty cool in 2018, looking at the role of autonomic neurons in epithelial healing. And there's been some data that Rob Hendricks has produced about the role of autonomic neurons in promoting inflammation and healing in a mouse model of herpes simplex keratitis. Altered local microbiome is likely to be happening there, and it may be playing a role in this disease, and we just don't know. And finally, I'm just going to say, I think iatrogenic factors are the single biggest reason that eyes get into trouble and why we end up with the disease and the pathogenesis. So let's look at risk factors for diabetic foot ulceration. This is in the literature for diabetic feet. Sensory neuropathy, deformity, age, repetitive trauma, prior ulceration, arterial disease, autonomic neuropathy, altered local microbiome, and infection. We're not talking about cornea, we're talking about the diabetic foot. And all this has been figured out way before we figured this out about the neurotrophic eye. Furthermore, every treatment that we've used in the eye has first been tried in diabetic feet. The current consensus for many years now that they've looked at this is that the things that you can control are deformity, repetitive trauma, and infection for diabetic feet. The current consensus strategy is to prevent breakdown. And every diabetic is taught this. So what about the eye? Well, look at the risk factors for neurotrophic corneal ulceration. And I've starred the ones that are similar. Sensory neuropathy, deformity, which means exposure and lash issues. Age, the older patients have more trouble. Repetitive trauma, prior ulceration. I suspect some of these eyes have anterior ischemic disease, especially those post-zoster. I suspect some of them have autonomic neuropathy and altered microbiome, but we don't know that yet. Infection and inflammation. And the one thing that's not on the diabetic foot list is calcific degeneration. So it turns out, what are the ones that we can control? Deformity, repetitive trauma, and infection and inflammation. And now with the work that Dr. Ali has brought to the field, maybe we can start getting into taking care of the sensory neuropathy as well. But taking the sensory neuropathy aside, the current consensus strategy should be prevention. Deformity, repetitive trauma, and infection and inflammation are the big issues here. And if we can control and prevent, we're going to be much better off than doing these various therapies. And I tell you, like I said, I've tried them all except the neurotization, and I've been pretty much not that satisfied. So these three are pictures of patients with completely neurotrophic corneas. And this is the issue. We talk about this as if they're all the same. This means central and all four quadrants, they have zero sensation. There's the one on the left, the one in the middle, one on the right. Why are the outcomes in the disease so different in these three, all with complete loss? Not, oh, I've got loss centrally in one quadrant, but complete loss of sensation. I would argue it's the diabetic foot problem. It's all about prevention. We need to protect against trauma, toxicity, and nocturnal incidents. And when I say that, I mean people traumatize their eye at night and nobody knows this, and no one talks about it. And we're going to talk about it a little bit. So why else does it end up in these cases? Because it's a misdiagnosis category. People make a false diagnosis, they miss it, and then those eyes don't get protected. They get treated with ways that are harmful rather than helpful. In my practice, the most common, people come in and are sent in as a dry eye. I'll say this about 3 times in this talk. These eyes, for the most part, are not dry. They do not have K-SECA. They come in as, HSV dendrites. And in fact, they're healing lines, as you can see centrally. And they may come in as this patient has a limbal stem cell failure. Maybe the limbal stem cells aren't functioning terribly well because of a neurotrophic problem, but the basic underlying problem is the neurotrophic keratopathy. And because of that, they've all been treated incorrectly and the diagnosis has been missed. Almost never do they come in saying this is a neurotrophic cornea and I need help. So how do we get clues? We heard about Gaucher-Bonnet. That's fine. Very few people have it. You got to sterilize it in between. Other people use cotton tip swabs. That's fine, but you get a different length and a different sort of thing every time you try to unpeel that. I use wax dental floss. I was taught this at the Proctor Foundation many years ago, and I find that it's very effective, and I can get reproducible results on a 0 to 4 scale of sensation. And I consider 0s and 1s the ones that potentially get into trouble. Usually it's the 0s where they can't feel it at all. So you got to test sensation. The problem is patients come in, most practices, they've been numbed up before you ever see them. You can look for subtle signs of neurotrophic keratopathy, and I haven't found this in the literature anywhere, but people with neurotrophic keratopathy get central intraepithelial cysts, the same kind of look that you get with chronic contact lens wear and with recurrent recurrent corneal erosion. They can be intraepithelial, or as they progress and get worse, you can get things showing up on the surface, and you can see just a little bit of staining in both of these pictures of subtle signs of neurotrophic keratopathy, and this is something that can be a clue for you. The other clue that people miss is poor epithelialization of corneal facets. Facets are thinning of the cornea after disease. In a normal, healthy cornea on the left, you can see a nice, smooth epithelium. Centrally, the epithelial healing in healthy corneas fills in those facets and ends up thickening up the epithelial cell layer so you get a smooth surface. But if you have a neurotrophic cornea, you don't get that. If you get to heal, you get a very altered surface with the epithelium not filling it in. And this is a real clue that you're dealing with neurotrophic keratopathy as well, something that is not written about or talked about. What are other diagnostic clues? Calcific degeneration. There's not a lot of things that give you calcific degeneration, and if you see it, especially in an older patient, you should be checking for a neurotrophic cornea. I don't understand why patients get this. Dick O'Connor had all kinds of theses and ideas in his AOS thesis, but you see this in like JIA patients, you get it in chronic inflammatory disease patients with uveitis, and you get it with neurotrophic keratopathy. So this should be a clue that you're dealing with a neurotrophic cornea. At least check. There are complicating issues when it comes to neurotrophic corneas. Certainly you've heard about distichiasis and trichiasis. One single lash, if you're not careful, will destroy these patients. Medication toxicity you've heard about, and I cannot emphasize how much this is a problem. Patients who have exposure, you've got to fix that because that'll complicate things. And patients who have rosacea, and rosacea is very common. You need to control the rosacea. Otherwise, the surface is going to be a problem. Finally, interstitial keratitis that's active, or zoster active pseudodendrites, which are infectious, both complicate this whole problem. You got to treat these underlying issues if you're going to treat the underlying problem and improve the surface. You can't just slap a membrane on without taking care of these other things. You can get a secondary infection. Here we've got Streptococcus, Nocardia, and ick in these cases. And actually taking care of these is extremely important if you're going to manage them. Further complicating issues, and this is the big one. And I'm hearing things on the telephone line, so if somebody isn't muted. Iatrogenic ocular surface trauma. I think this is the biggest issue with these patients. They hit their eyes with their eyedropper. You heard that from two other speakers, but what you didn't hear is they then wipe their eye with facial tissue, with their eye open, trying to blot it. They hit their eye's surface, including the cornea, with mascara brushes when they're trying to put on their makeup around their lashes. And there are nocturnal events, if you don't protect the eye, where they touch the eye and irritate it. On the left was the patient that taught me this. This patient, I said, it looks like you've had trauma nasally. Show me how you put in your eye drops. And they showed me how they put in their eye drops, and they hit the corner of their eye. They said, oh, I'm doing it right. Look, I'm way over on the side. They hit the surface, completely unaware of it. And then they put the bottle down. They took the Kleenex, and they wiped it across the surface. And so I started asking all my patients, show me what you do. And it's unbelievable how often this happens in your neurotrophic keratopathy patients. The middle one was a patient who said, oh, look, I put my eye drops in just great. And in fact, they were terrific at putting your eye drops in. And then they picked up the facial tissues and wiped it across their cornea. And that's what that lesion's from. All the way on the right is a mascara brush pigmentation and tattooing in a patient with a neurotrophic cornea who claimed they were listening to everything that the referring doctor had told them to do. So if you think your patients are putting in the drops right, you're probably wrong, because there have been at least 6 studies in the literature of glaucoma patients who use drops all the time, and basically up to 80% of glaucoma patients are unable to correctly instill their eye drops. And it's more of a problem in the elderly. And if you think it's a problem with glaucoma patients where they can sense the ocular surface, imagine what it is with patients who have no corneal sensation. People talk about proper eye drop technique, like over on the left here. I teach my patients a different way. I have them lay down flat on their back. I have them put the bottle across the bridge of the nose, look up at the tip, and squeeze, and it falls in, and they avoid trauma as much as possible. They still probably do things that we're unaware of. The other thing is I ban facial tissue and eye makeup from these patients. All my neurotrophic keratopathy patients get what my residents and fellows call the eye drop, Kleenex tissue, and mascara talk, because prevention is the big issue here. We need to prevent this. I minimize eye drop use and epilate lashes. That's the chemical and mechanical trauma of all this. Vigilance on the lashes. One lash will destroy it. And patients come in with a bag full of drops, as you see here. And ointments are even worse, because patients hit themselves with the ointment all the time, or their finger trying to put it in. By the way, as far as I can find, there is no data to support that lubrication helps corneal wound healing or neurotrophic keratopathy, and that it speeds healing. And if anyone's got a great reference, I would love to see it. I can show you that there is some data on artificial tears and wound healing, and most of the data shows nothing. There is a study done basically on neurotrophic keratopathy in monkeys, in squirrel monkey, and that's presented here. It's back from 1973. Most of the eyes with neurotrophic keratopathy are not dry. They don't have a tear deficiency. And there's no data that I know for lubrication preventing or healing neurotrophic ulceration. Once again, this is in squirrel monkeys, and it shows you that with lubrication, there's no difference in wound healing. This is in monkeys. We're not talking about mice or even rabbits. So if there's better references, I'd love to find them, and if you guys have it, let me know. I'm not big on using eye drops unless they're truly dry, K-Sika, but I do protect the eyes in multiple ways with whatever works for the patient. Using the press patch, this is a congenital patient that I had who used to wear this at night and alternate one eye and then the other. This works pretty well. Onion goggles work tremendously well. You can get them online for between 10 and 20 bucks. They cover the eyes, they protect patients from hitting them accidentally, and they seal because they have this foam sort of ridge along them. If you want something cheaper, pugs are about $5. They wrap around and actually cover the eyes up very well. I tend to put patients initially, before I even do that, in shields at night or breathe right strips at night, because if I can just protect nocturnal incidents, these patients do much, much better in terms of not breaking down and even healing. Some of my patients have come in and said, hey, blue painter's tape works great or duct tape works great, whatever works for them. I will emphasize that nocturnal protection is probably more important than daytime protection. I give my patients social breaks during the day. I tell them go ahead and be out for 2 to 3 hours without it and then put it back on. This works. This also works as therapy. You heard about various therapies that they say, oh, in 48 weeks we get healing. You get healing in less time than that if you do these procedures. So there's nothing wrong with this, and it's a lot less expensive, and ultimately then the patient gets used to it for prevention. Would you rather have a patient basically in goggles like this or over here having a tarsorrhaphy? And in the tarsorrhaphy cases like this patient kept hitting their eyes, and we ended up having to do a full tarsorrhaphy on them. So I'd say I'd much rather have them in goggles. It's more cosmetically acceptable, and they can take them off in social situations. Infection and inflammation, I use antibiotic prophylaxis when the epithelium is broken down. I use it once daily, polytrim or preferably moxifloxacin because it's non-preserved. I use antivirals extensively for my HSV and VZV cases orally. That way there's nothing topical screwing up the surface. I use azithromycin by mouth, doxycycline by mouth, and metronidazole to the face in my rosacea patients. Helps calm things down. And if I have to use a steroid, and you do in some cases, to calm down inflammation in the cornea, I use non-preserved, non-particulate steroids. And generally non-preserved dexamethasone made up by a local compounding pharmacy. I find that this is much better than using even Lotamax ointment, which some people say, oh, it's non-preserved, it's good, but people hit themselves in the eye with ointments. With this, they tend to do pretty well. By the way, all the steroids that we have that are suspensions have particulates, not only the steroid particles, but they have round glass beads in them to make things go into suspension. And you're hitting the eye with those particulates when you put them in. Calcific degeneration, I would say avoid treating if possible. Why? Because poor epithelial healing occurs afterwards, and irregular astigmatism that you cannot correct except with a scleral contact lens occurs afterwards. So be prepared to put this off as much as possible. Usually you're not going to improve anyone's vision. Here's a case example I just want to finish with. This is a patient who had a completely neurotrophic cornea exposure and OSSN. He had a long history of squamous cells on the face. He's had chemotherapy, surgery, and radiation. He healed with 1 month of patching. He's got a neurotrophic ulcer here. And then after a month, we treated him with interferon alpha 2B. 2 months later, basically, look, the guy looks great. We stopped all drops except Moxie once a day. We gave him the eye drop and tissue talk. We patched for 1 month, 4 weeks. And his epithelium was completely healed. If he came back sooner, he might have been, but he didn't come back till 4 months. And then we did the interferon. So, risk factors for neurotrophic corneal ulceration. I've listed them here. The ones that we can really have an impact on are deformity, which is exposure and lash issues, repetitive trauma, which is mechanical and chemical in our case, and infection and inflammation, just like the diabetic foot, all three of these. And now we've got this neurotization, which may help us with the sensory neuropathy. So my feeling is the current consensus strategy should be prevention and should be basically using techniques like this to help them out. You heard in the tarsorrhaphy cases where they showed you the data, these eyes were healed like in 2 to 3 weeks. It's taking 4 to 8 weeks in various trials if they heal at all. So this is ophthalmology's diabetic foot problem, neurotrophic keratopathy. We need to protect the eye to prevent ulceration. The role of iatrogenic injury has largely been overlooked in our field. We need to minimize meds and lubricants, avoid facial tissue, and cease mascara. We have to question the use of amniotic membrane contact lenses in keratectomies. Try to find prospective trials on these. We need to patch, tape, shield, goggle, whatever we need to do. And in my hands, and I see a lot of neurotrophic corneas, and I've been doing this for a long time, they're quite effective for prevention and treatment. 100%? No. But they're very effective in most patients, and most will heal in a fairly short order. And they're cheap. Most eyes with neurotrophic keratopathy are not dry, and there's no data that lubrication is therapeutic. And finally, I think we need to look at the role of autonomic neurons in the microbiome as we study pathogenesis and how we want to manage this. So I once again want to thank everybody for your attention. It was great being able to sit here in my Pink Floyd t-shirt and old running shoes and give this. And I hope I arose some controversy and that you got something out of this talk. Once again, thank you very much for allowing me to have this opportunity.